In 2021, the AMA significantly revised the documentation requirements and methodology for selecting a level of service for ambulatory office encounters. The 2023 revisions extend these changes to inpatient admissions and subsequent visits, inpatient consults, outpatient consults, emergency services, in addition to others. In this video, I will review the changes, go through the steps for selecting a level of service, address time-based billing, and provide examples while demonstrating the use of my level of service calculator. Prior to 2021, selecting a level of service required using a combination of documented history, physical exam, and medical decision-making. With the 2023 changes, the documentation and number of specific history and physical exam elements has been removed for all of the encounter types. An appropriate history and physical examination needs to be documented. As far as what an appropriate history and physical exam is, the guideline leaves this up to the provider. This means that selecting a level of service now only relies on medical decision-making or the use of time-based billing. There are three elements of medical decision-making that are used to determine a level of service. These include the number and complexity of problems, the amount and/or complexity of data reviewed and analyzed, and the risk of patient management. Each of these elements are assigned a level, which are then used to determine an overall level of service. The levels are straightforward, low, moderate, and high. The process for evaluating the level assignment is somewhat different and will now be reviewed. Step 1 in choosing a level of service involves assigning a complexity level to the number and complexity of problems addressed during the encounter. The number and complexity of problems is best understood by breaking the problems addressed into acute versus chronic when trying to assign a level. For chronic problems, the progression from lowest level to the highest is logical. First of all, per the guideline, there are no straightforward chronic problems, so the first level we start with is low. Low includes one stable chronic problem. Moderate includes two stable chronic problems or one uncontrolled problem. And high includes a chronic problem with severe exacerbation, progression, or side effect from treatment. For acute problems, straightforward includes a self-limited or minor problem. The guideline defines a self-limited or minor problem as a problem that runs a definite and prescribed course, is transient in nature, and is not likely to permanently alter health status. Keep this in mind as I'll come back to it shortly. Low includes two or more minor problems. One acute uncomplicated illness or injury, which refers to a short-term illness with a low probability of morbidity or mortality, where full recovery is expected with treatment. In the ambulatory setting, this also includes self-limited problems that are not following the usual course or where treatment is considered. This brings me back to the straightforward level. In my personal opinion, there are not many examples I can think of in my daily practice that meet the straightforward level, as most problems that patients bother to present for require considering a differential diagnosis and offering some sort of treatment, even if as simple as putting on a bandage or advising skin moisturizer. In considering alternatives and treatments, the problem by definition becomes an acute uncomplicated illness. For hospitalized patients, the definition of acute uncomplicated illness is the same, except that the treatment is provided in the hospital. A low level is also assigned when a hospitalized patient's illness is stabilized and the patient is improving. The moderate level includes an undiagnosed new problem which has a differential diagnosis that includes a high morbidity or mortality risk problem if left untreated. An acute complicated illness is defined as illness that causes systemic symptoms and has a high risk of morbidity without treatment. In this guideline, they clarify that general systemic symptoms such as fever and body aches alone do not constitute systemic symptoms. However, specific symptoms of even a single organ system that may indicate a high-risk condition would count. An acute complicated injury is one which requires evaluation of body systems not directly related to the injured area. If the injury is extensive, or if there are multiple treatment options, or if the options have a high risk of morbidity. Finally, the high level includes an acute or chronic injury that poses a threat to life or bodily function. The second step in determining a level of service is to consider the data reviewed or analyzed and assigning a level, similar to step 1. Admittedly, this step is a little more confusing, but with a little practice can be mastered without too much difficulty. First, let's define what counts as data that can be reviewed or analyzed. Tests include imaging, laboratory, psychometric, or physiologic data. Each unique test or panel that is ordered or reviewed counts towards data complexity. For example, a complete blood count would only count as 1 point. You don't get a point for each component of the CBC, and you would only get 1 point even if you both order and review the CBC. Of note, if you took credit for ordering a test in a previous encounter, you can't take points for reviewing it in another future encounter. Similarly, you can't take points for ordering or interpreting tests, such as an ECG, if you are also billing for the interpretation of that study. No double dipping. You also get a point for each note reviewed, other than from those of your own practice, and also from external documents from healthcare professionals or organizations. For example, you would get a point for reviewing a discharge summary from an outside hospital, and an additional point for reviewing a specialist note in your EHR, assuming it was medically necessary. History provided by an independent historian such as a caregiver, friend, or guardian counts as a data point when the additional history is judged to be necessary. Examples include a parent providing history for a child, or an individual providing history for a patient with a cognitive, developmental, or intellectual disability, or for a patient who may provide an unreliable history. Of note, interpreters are not included in this category. Now that we know what counts as data, we need to assign a complexity level to it. Straightforward is when one or less data points are reviewed or analyzed. Low complexity is when 2 data points are present. Also, even though a single point is taken for an independent historian, having one without any other additional points counts as a low-level complexity. Examples of low complexity data include ordering a CBC and reviewing a specialist note, 2 points. Getting history from a parent regarding a child's illness. Moderate complexity should be assigned when there are any combination of 3 or more data points. For example, ordering a CBC, reviewing a specialist note, and having an independent historian. That would be 3 points. You can also assign moderate complexity if you independently interpret a test which normally comes with a report and interpretation, for example, an ECG, radiology, or PFTs. As a reminder, you can't count this if you are also the billing provider providing the official read of the test. Finally, you can assign moderate complexity for discussion of management or test interpretation with an external physician or other qualified healthcare professional, or an appropriate source such as a teacher, lawyer, or case manager. Family members are not included in this category. High complexity data review is assigned when 2 or more moderate complexity conditions have been met. For example, if you order a CBC metabolic panel at an ECG and you provide your personal interpretation of the ECG. The risk of complications and or morbidity and mortality of patient management is the final step in assessing a level of service. The level of risk is based on the consequences of the problem when appropriately treated, and also based on the decision-making related to initiate or forego further testing, treatment, and or hospitalization. To the first point, some management options may not occur often, but when they do, carry a high risk of morbidity or mortality. For example, a significant drug reaction to a prescribed medication. Other management options may have a high probability of side effects, but are of a low-risk nature. For example, mild abdominal cramping in a patient treated with over-the-counter laxatives for mild constipation. The assignment of a risk level is the most subjective of the 3 elements, and the guideline acknowledges this by essentially saying that trained clinicians can use their judgment in assigning risk and selection of a particular risk level does not require quantification, but may be quantified when evidence-based medicine has established probabilities of risk. That being said, they do provide some examples of what should be considered moderate and high risk. Examples of moderate risk include prescription drug management, diagnosis or treatment significantly limited by social determinants of health, minor surgery in a higher surgical risk patient or procedure, elective major surgery in a lower surgical risk patient or procedure. Of note, moderate risk can be assigned even if the patient decides not to undergo surgery, as long as the options are discussed. Examples of high risk include drug therapy requiring extensive monitoring for toxicity. For this example, intensive means at least quarterly, and the monitoring is for toxicity rather than therapeutic effect. Monitoring may mean checking drug levels, surrogate markers of toxicity such as liver function tests or blood panels, performing physiologic tests, or obtaining imaging. If assigning risk based on drug therapy, the monitoring must be ordered or obtained during the encounter. Parenteral controlled substances. Decisions to hospitalize or escalate care in an already hospitalized patient. Decisions to not resuscitate or de-escalate care due to poor patient prognosis. Elective major surgery in a higher surgical risk patient or procedure. Emergency surgery. Once you have assigned a complexity level to each of problem complexity, data review, and risk, the next step is to figure out the overall complexity level for the encounter. To select the overall complexity level, 2 out of 3 of the assigned levels must meet or exceed a level in order to select it as the overall complexity level. For example, if you have low problem complexity, moderate data complexity, and high risk complexity, the overall complexity is moderate. Similarly, if you have a low problem and data complexity with moderate risk complexity, the overall complexity is low, as the problem and data complexity are the 2 out of 3 elements that are at the low complexity level. The final step is to convert the complexity level to a level of service for the encounter. Outpatient, emergency, and consult encounters are based on a 5-point scale. Hospital initial and subsequent visits are based on a 3-point scale. These two tables show the conversion between complexity level and level of service. Essentially, for hospital encounters, straightforward and low are combined into level of service 1. Now we'll review a couple of examples and use my free online coding calculator to demonstrate the process. Case 1 is a 3-year-old with fever, nasal congestion, and mild cough for 2 days. Is otherwise well, presenting to their pediatrician's office. A COVID test is ordered. Supportive care recommendations such as nasal saline, humidifier are made. For the problem complexity, I would consider this an acute uncomplicated illness, which would be classified as low complexity. For data complexity, we have 2 data points, the COVID test and a point for the history being obtained by the parent. Of note, even without the COVID test, the independent historian would allow the data complexity to be classified as low. For risk complexity, I would also call it low because the supportive measures are of relatively low risk, but may not be comfortable for the patient. Since this is an outpatient encounter, the complexity levels convert as follows. The problem level is 3, the data level is 3, and the risk level is 3, and so the overall level is 3. Using the outpatient CPT code set, this would be a 99213. Case 2 is a 6-month-old female with 2 days of fever without respiratory symptoms, decreased feeding and urination, but well hydrated, presenting to the emergency department. A urinalysis, urine culture, and COVID test are obtained. The urinalysis has nitrites, leukocytes, and red blood cells. Culture and COVID results are pending. The patient was prescribed cephalexin for empiric therapy for UTI with plans to follow up the culture and COVID tests. In this example, I would consider the problem moderate complexity due to the constellation of systemic findings of fever and decreased feeding and urination. Of note, if the patient only had fever, this would more appropriately be low complexity. For data, there are 3 tests ordered, and the UA was reviewed at the time of the encounter. 3 points are counted for the tests, as you don't get separate points for both ordering and reviewing a result. You also get a point for an independent historian, so the total points for data is 4. This translates to an overall data complexity of moderate, as 3 or more points is considered moderate. The risk of the problem is also moderate due to the decision to prescribe antibiotics. Converting the complexities to levels yields 4 for problems, 4 for data, and 4 for risk, giving an overall level of service of 4 with an ED service code of 99284. By the way, if you had selected low complexity for the number and types of problems, it would still have been a level 4 overall because 2 out of the 3, the data and the risk, were at level 4, making the problem level irrelevant. In this last case, a 46-year-old man is day 2 of hospitalization for a COPD exacerbation. He's responding to breathing treatments, antibiotics, and IV corticosteroids. He's still requiring oxygen, but oxygen saturations are improving. His blood counts are stable, and his metabolic panel shows stable renal function and normal glucose. For the problem complexity, it would be classified as a stable acute illness, and thus low complexity. For data, pulse oximetry, blood count, and metabolic panel allow for 3 points, which translates to moderate complexity. For risk, I would assign a moderate level of risk, as the prescribed treatment has moderate risks of morbidity. Converting the complexities to levels of service yield level 1 for problem, level 2 for data, and level 2 for risk. 2 out of 3 meet or exceed level 2, and so the overall level of service is 2, with a subsequent hospital encounter code of 99232. After practicing for a while using a coding calculator, this will become easier over time. Now let's switch to time-based billing, which is thankfully much more straightforward. Encounters may be billed using either medical decision-making or time. The only exception is that emergency service codes cannot be billed based on time. However, critical care time can be billed as appropriate, but this is out of the scope of the tutorial. One of the best revisions of the new guideline is that now both face-to-face and non-face-to-face time spent in the management of the patient is counted in calculating the level of service. Almost all activities related to the care of the patient counted time spent in patient management, including writing your notes. Activities not allowed include time spent teaching, traveling, or performing separately billed services. Again, no double dipping. For each type of encounter, a typical time is assigned to each level. To bill a level, the total time spent must meet or exceed the typical time. The tables show what the typical times are for different types of visits or encounters. If you exceed the highest level of service by at least 15 minutes, you can start billing units of prolonged services. For each full 15 minutes beyond the typical time for the highest level, you can bill a unit of prolonged service. It's been my experience that time-based billing may yield a better level of service than medical decision-making for acute care outpatient encounters, but I recommend always comparing the two to make sure you get the highest appropriate level of service for your work. I hope this presentation has been helpful in explaining the logic behind selecting an appropriate level of service based on the 2023 AMA CPT Guideline. Please feel free to use my coding calculator, which can be accessed at www.providercodeit.weebly.com to help you in your coding efforts. Finally, while this presentation represents my own views and opinions, I would like to thank Danielle Davis and Jessica Ferrari for their many years of education, fact-checking, advocacy, and support. Their expertise has been greatly appreciated, and without whom this presentation would not have been possible.